Okay, good afternoon.
Good afternoon, ma'am.
Good afternoon, ma'am.
Okay, so for this afternoon, we will have our small group discussion covering good afternoon, hypertension in pregnancy.
Good afternoon, ma'am.
Okay. Okay, so you've had your lectures in your undergrad, in your second and third year in obstetrics, as well as your lectures last week for this topic. Okay, so I expect again participation on your end in our discussion of this case. All right. Okay. So okay. So what happens is at the outpatient, you see a pregnant patient seeking consult to you as her first prenatal checkup. Her last menses was on February 6, 2021, and upon doing initial vital signs, you found out that her blood pressure was 130/90. Okay. So what are the additional information that you will need to manage this patient? J. What are the questions that you will ask that so that you could establish one, where is she in the hypertensive spectrum of pregnancy? What are the additional things that you should know?
Ma'am, we should ask her if she was hypertensive even before conceiving.
Okay, you could ask if she was hypertensive before she got pregnant. Okay, what else?
Also include the family history if anyone else in the family has hypertension.
Pertinent is if she has any family history of hypertension. That's correct. What else?
We can ask whether she has diabetes.
Okay, we could ask if she has diabetes as well. Okay, what else?
In the personal social history, we ask if she is a smoker or
Okay,
drinks alcohol.
smoker or an alcoholic drinker. Okay, what else?
We can ask the past medical history, that maybe she's having other problem also.
Past medical history that may point out to other problems. Okay, what else?
If she's taking any medication for high blood pressure.
Any medication?
Yeah.
What else?
Ma'am, we can also ask her if this is her first pregnancy because we don't know if she's primigravida or multigravida.
Okay. What gravidity and parity? Okay. So those are indeed risk factors. What would point to a higher risk of
Her race, ethnicity, and socioeconomic status.
socioeconomics? Okay. Higher risk. First baby, second baby.
First baby, primigravida.
Primigravida would have higher risk of preeclampsia. Okay, that's correct. What else? What else would you ask? It's purposely just a pregnant patient with a high BP because I want you to ask what are the important things that you should know.
Maternal age, ma'am.
Maternal age, that's correct. Okay, what else? So You ask for the age, you ask for gravidity and parity. Of course, we ask for the other things. But these are, in a hypertensive patient, these are the things that we should focus on. Okay, what else?
We can ask whether the patient is obese or not.
Okay, you would ask or you observe if the patient is obese or has a pregnancy BMI that would exceed your limits. What else?
The gynecologic history, menarche and
Okay, your usual
Ask
menarche.
about
What could
physical
you tell
activity.
about the age of gestation? Will
7.
it matter? If your last menses was February 6, 2021, what is the age of gestation and will it have an ho- how will it affect you managing this patient?
18 weeks, 4 days.
She is at 18 weeks.
Yeah.
Okay. So what does this tell you? If you are going to do a targeted physical examination on this patient,
She has hypertension before 20 weeks of gestation,
okay,
like chronic hypertension, doctor.
so this at this point, you are thinking she has chronic hypertension. For example, her last menses was January 6, 2021. What would your working impression be then? You're just changing the age of gestation.
Ma'am, then it would be pregnancy-induced hypertension.
It could be pregnancy-induced hypertension. Although we know that pregnancy-induced hypertension would be a wastebasket diagnosis and it would take up to 6 weeks postpartum for us to really tell if it is just pregnancy-induced, depending on what will happen to the course of the pregnancy of this patient. Okay. If you are to do a targeted physical examination on this patient, what are the signs and symptoms that you have to elicit to make sure that there are no complications of hypertension for this patient?
Weakness, nauseous,
What?
weakness or nauseous of the patient.
Blood pressure? What else?
Ma'am, CBC liver function test.
Oh, we are still at physical examination.
If she has any abdominal pain.
Okay, we ask for abdominal pain. Particularly, what kind of abdominal pain are we looking for?
Epigastric pain.
What?
Epigastric.
Epigastric pain. What is the pathophysiology of that epigastric pain?
Ma'am, liver capsule. Hemo.
Stretching of what? You're correct. It's a liver capsule. What's the name
Hematoma.
of the liver capsule?
Liver capsule hematoma.
What is the name of that liver capsule? Do you remember in your previous lectures? What in particular is stretch? Actually, what is the name of that liver capsule that you are talking about? Anyone? It is stretching of the what? And that is the pathophysiology of your epigastric pain in preeclampsia.
I'm stretching of Gleison's capsule.
Okay, it's the stretching of your Gleason or Gleason's capsule. That's correct. Okay. What else? What other signs and symptoms should you elicit? What?
Blurring of vision, ma'am.
Okay.
Ma'am, headache and blurring of vision.
Okay. One other is your blurring of vision to make sure that there would be no neurological or your vision changes. That's correct. What else would you look out for?
Increased knee jerks.
What would cause increased knee jerks at this point in time? So what are the other symptoms? Blurring of vision, headache, epigastric pain. What else should you look out for?
Proteinuria, ma'am.
Any changes in the urine? Okay.
Yes, ma'am.
What else?
Edema, doctor.
What?
Edema.
Edema. Edema used to be so much a part of your preeclampsia symptoms, but now it's a lesser indication of your preeclampsia, and it's rarely used as a criteria. But an edema, when you look at it, you clinically think that there may be hypertension present. Okay, so these are the signs and symptoms. Of course, you have your other physical examination of pregnancy that you would have to look for. Of course, do not forget your abdominal and your internal examination. But when you're hypertensive, you ask for blurring of vision, epigastric pain, and headaches. Okay. So what are the laboratories that you will request for this patient? What are the baseline labs? In short, in other words, my question is, what are the baseline labs that you would have to ask for in a hypertensive patient over and above your usual OB normal laboratories?
Liver enzymes
Okay,
test.
you will ask for your liver enzymes. What else?
Serum creatinine.
Serum creatinine. Okay.
Urine
Don't
analysis.
You don't get your serum creatinine without your BUN as well. Okay. Urinalysis. How else will you assess your urine? What else would you look for in your urine so that it will point point to a preeclampsia? Is it just chronic hypertension?
Like proteinuria, doctor.
Okay, you look at your proteinuria. So your urinalysis would just give you a +1, +2, +3, or +4. If you want to quantify it, what will you request for?
Serum uric acid.
24-hour urine excretion.
You have your 24-hour urine protein. All right. You also ask, I do agree, some although not always in the criteria, we ask for uric acid also. If it's increased, it also points out to a worsening preeclampsia. What else? Have you
hemoglobin and hematocrit.
Okay, of course, you look at the hemoglobin, hematocrit. What else will you look at your CBC? What else is important?
Platelet count.
Okay, you particularly look at your platelet count. Okay, what else? What else? What other labs would you request for to establish preeclampsia or to establish a baseline?
Partial thromboplastin time, ma'am.
PTT.
Antiphospholipid antibodies.
What?
Antiphospholipid antibodies.
Antibodies. What else? You're missing one in your preeclampsia laboratories.
Uterine artery Doppler.
Uterine artery.
Doppler.
You could, but not at this early stage, but Doppler is also a big part of your fetal surveillance. Okay, we will get back to that later. What's the other? What's the laboratory that you are missing?
Serum transminase.
What?
Serum transminase.
Serum
Transminase.
transaminase. What? Not so much. What else?
Alanine aminotransferase.
Your AST/ALT already mentioned. Your liver enzymes.
How about LDH and bilirubin?
Okay. At least your LDH. What is your LDH? What does your LDH mean?
Lactate dehydrogenase
Okay,
test.
it's your lactate dehydrogenase. Okay. So you assess this patient, you requested for the labs. Before you send this patient home, how will you manage this patient? How will you advise this patient? One. Second, what are the medications that you could give this patient at initial consult?
And we can give her aspirin and suggest to do exercise. I mean, not complete bed rest, minimal
Complete bed rest. Okay, I agree. Aspirin, what dosage? Would you know the dosage of aspirin?
100 to 150 mg per day.
100 to 150. Usually, aspirin is given 80 milligrams once a day. Okay. Exercise, you give adequate exercise, not necessarily bed rest, but of course, everything in moderation. What else? What else will you advise this patient to manage her at this point in time?
Ma'am, dietary changes.
Again, I'm sorry.
Diet changes.
Sorry, I can't understand. What?
Diet changes.
Sorry, please speak clearer.
Diet food.
I means dietary.
Diet change.
Oh, diet. Okay. What kind of diet will you encourage this patient to have?
Low sodium, ma'am.
Okay, low sodium, low fat, low salt diet. I agree. Okay, what else? How else will you manage this patient?
And we can ask them to monitor their BP daily.
We monitor their BP. Okay, if they have a blood apparatus at home, monitor their BP. Okay, what else?
Calcium supplements.
Okay, what are the supplements that you will give?
Folic acid, ma'am.
Okay, we give your folic acid. What else? What else? How will you treat this patient? Aside
Antioxidant.
from your usual vitamins,
Yeah, vitamin
the
C,
pregnant,
E.
what will you give this hypertensive patient? You've given aspirin. What is aspirin for? Why do we give aspirin to hypertensive patients?
It is thromboxane A2 inhibitor.
For?
To make blood less viscous, I think.
Less viscous, and thereby they say
Decreasing.
they decrease the chances of preeclampsia. What else?
We can give methyl dopa, doctor.
Okay, what is methyl dopa?
Alpha methyl norepinephrine.
What is methyl dopa?
This is active form of alpha methyl norepinephrine.
Okay, and then? So what is it? What is its
It
mode
will-
of action? What is the mode of action of methyl dopa?
Doc, we give it orally.
Yes, we give it orally. What is its mode of action?
Vasodilation of blood vessel.
Vasodilation. Okay, so it's the only hypertensive agent that you could use, oral hypertensive that you could use in pregnancy. One of the, okay. Labetalol is the primary, but it is not available in the Philippines. Okay. How are you to give your methyl dopa?
250 to 500 gram.
So you start at 250 milligrams.
Yes.
3 times a day. Okay.
Yes.
So what is your maximum dose? How high can you go as far as methyl dopa is concerned?
3 gram.
Okay, that's good. You could go as high as 3 grams per day. So how many tablets is that if your formulation is 250 milligrams 3 times a day?
12.
So around 12 tablets, you could give as high as 4 tablets 3 times a day. That is your maximum dose. So before you say that it's uncontrolled hypertension, you more or less should reach 12 tablets per day. Sometimes your patients are very concerned because you're asking them to drink 12 tablets per day. But I've already asked this. 250 milligrams is the formulation because also of cost. The 250 milligram tablet would cost around 20 pesos. And your maximum dose would cost around 240 pesos per day. And of course, it's easier to titrate if you have a 250 milligram formulation. All right. Okay, so you gave this patient methyl dopa, you asked for laboratories, and you asked the patient to come back after 1 month. However, patient did not come back and came back after 3 months. Okay? with these following laboratory results. Okay. So what's your working impression at this point? What are your expected findings as far as hemoglobin? I'm sorry, I failed to include your hematocrit. Hemoglobin, hematocrit, and platelet are concerned. What's the value that will alarm you that your platelet is decreased?
Less than 100,000.
Okay, some will say less than 100,000. Mild preeclampsia could be less than 150. Okay, well, how would you know if your AST and ALT are in the range values? Is it enough that it's slightly increased? What are the values that you would say that your AST and ALT would be elevated? How many times elevated are we looking for?
Ma'am, if it's raised 2 times the normal, then it usually
Two
indicates.
times the normal would alarm us that it may be impending preeclampsia. How high should your LDH be?
More than 600.
More than 600. And what are the levels of your 24-hour urine protein?
300 mg.
300 mg per 24 hours. Okay. So at this point, what is your working impression? Is it still pregnancy-induced hypertension? Or because patient is 18 weeks under, you could say that it is chronic hypertension. Okay? So if it's more than 20 weeks, this is pregnancy-induced hypertension. If we follow the LMP given in this case, it is what? It is chronic hypertension without preeclampsia because our lab results are within the normal range. Okay. Your preeclampsia laboratories, okay, it's either your what criteria that what would these laboratories tell you if it's the range? What syndrome will it fall under?
If it's high.
If it's high, what's it called?
Hypersensitivity.
Aside from preeclampsia, and it will tell you the severity of your preeclampsia and thereby help you in deciding if you will terminate the pregnancy or not.
Ma'am, it is helper syndrome.
Okay, what does HELP syndrome mean?
Ma'am, it consists of hemolysis, then elevated liver enzymes and low platelet counts.
Okay. You have evidence of hemolysis, elevated liver enzymes, and low platelet count. Okay. Would you know the two criteria used? Did you encounter in your readings? As far as your HELP syndrome is concerned? So you have your Mississippi and you have your Tennessee criteria. Okay. they would have different values, and we use our Mississippi criteria more often. Okay. So after 2 months, did not go back after a month, and after 2 months, your blood pressure was found to be at 140/100. Okay. What are the questions again that you will ask patient at this consult?
We can ask ma'am if she has noticed any vision changes like blurring of vision.
Okay, still the same. You look at your blurring of vision, headache, etc. What's the difference after 2 months? Why is it expected that your blood pressure would be higher at 18 at 26, around 26 to 28 weeks? Is it expected, or did the patient not follow your instructions? That's why your BP ended up higher. But you found out that your patient has been religious in taking her medications. Patient followed the diet, etc. Followed every instruction. But what happened at 26 to 28 weeks? Is this expected? Is this expected? What have you learned with regards to hypertension in pregnancy and how it relates to your age of gestation?
Ma'am, it might signify that the patient might be having signs of eclampsia, I mean preeclampsia or eclampsia, because she is not, because the BP is not being within normal range.
What can you say about the age of gestation? Is it expected that at around 28 weeks, your blood pressure would increase? And why is that so? Go back to your cardiac changes in pregnancy. What have you learned?
Increase in cardiac output.
Okay, so there's increase in cardiac output expected in at around 28 weeks. So this is expected. Okay. So how will you manage this patient as far as fetal and maternal surveillance is concerned?
And we can do uterine Doppler test.
What?
We can do investigations like a uterine artery Doppler test.
Okay, we ask for uterine artery Doppler. We repeat your pre-eclampsia labs. Okay, that will help us to decide. Okay, so these are your lab results as far as your pre-eclampsia labs are concerned. Not any different from what we had as baseline. So this is not a problem. Okay. This is the result of your Doppler. Okay. Your Doppler velocimetry shows elevated values for both umbilical and uterine arteries, both uterine arteries with end diastolic notch. How will you manage this patient?
We'll give magnesium sulphate to prevent eclampsia.
will
program
we already give magnesium sulfate?
along with antihypertensives like methyl dopa.
Okay. You will still give methyl dopa. Do you mean you will admit the patient already?
No need, I think, ma'am, because
Will you
she is
terminate
not
this
severe.
patient? Will you terminate the pregnancy of this patient?
No, ma'am.
What will you do? Give hypertensives and have close fetal surveillance. Okay, after 2 weeks, your surveillance showed this Doppler results. Shows absent and diastolic flow, elevated indices in the uterine arteries. How will you manage this patient? Will you terminate at this point? What does your absent and diastolic flow mean? What is its significance? Okay lang. What is its significance?
Ma'am, it indicates that the baby is not getting, the blood flow is not good.
Okay. It's not getting adequate blood flow anymore. Is it the most ominous? More ominous would be your reversed and diastolic flow that would be equivalent to your Eisenman derivation. But absent and diastolic flow, you are to terminate pregnancy and you have to get the baby out because it is not conducive anymore to further keep the baby inside. So this is around 30 weeks after 2 weeks. So what will you do as you terminate the pregnancy of this patient? What will you give?
Ma'am, steroids for fetal lung maturity.
Agree. You give steroids for fetal maturity. Okay, what else? How will you manage so now it's 140-100, your patient has preeclampsia with severe symptoms. Okay. How will you manage the preeclampsia of this patient? What's the cornerstone of management?
We should give her magnesium sulfate also to prevent convulsions.
Okay. Magnesium sulfate is given to prevent convulsions. Agree. How do you give your magnesium sulfate?
Uh, 4 to 6 grams diluted in 100 ml of normal saline.
How?
It is diluted in normal saline and given to IV.
And give it at
IV over 15 to
IV.
20 minutes.
Okay, some would say 1 to 2 grams per hour, etc., etc. Okay. So know your dilution. Others still give it buttocks, slow IV push, but that was before. Okay. What else? How will you control the hypertension? You've maximized your oral methyl dopa. What's the next management for hypertension? How would you bring it down? What's your hypertensive medications intravenous that you could use?
Hydrolazine.
Okay. How do you give your hydrolazine?
Hydrolazine, 5 to 10 mg.
Okay, usually 5 milligrams up to 3 doses every 15 minutes. If still it doesn't go down your blood pressure, what else can you give? What do you give?
Diuretics.
Diuretics. You have to control your BP fast. Your diuretics would not control it fast enough. What will you give? What will you use?
We can give a nifedipine.
Nifedipine. Others will use nicardipine because your nicardipine would have a drip form. Okay. So you gave your MAG, you gave hypertensive, you have your steroids. Route of delivery, since this is preterm, most likely your cervix is not dilated, you do an emergency cesarean section. Okay. Is it important you got the baby out? How will you monitor this patient post-op? You are giving magnesium. Patient is hypertensive. What are the things that you have to look out for post-op?
Ma'am, we should make sure that she is not getting a magnesium sulfate toxicity.
Okay. What are the symptoms or effects of magnesium sulfate toxicity?
Patellar reflex is lost, and the patient also might have slurring of speech.
Patellar reflex is one. What else?
Slurring of speech.
Is slurring of speech included? What are the things that you look out for in a patient that you are giving magnesium sulfate to? I agree with your deep tendon reflexes. What else?
Respiratory arrest.
Okay, respiratory depression is another. And what's the other? I think you mentioned it a while ago.
Cardiac arrest.
Urinary output.
Okay, you look at your urine output. Okay.
And oxygen
Would
saturation.
would you know what levels, at what level would your deep tendon reflexes disappear, I mean? At what level would your urine output be affected, and what level of magnesium would your respiratory depression appear? What levels?
Deep tendon reflex at 9.6 to 12 milligram per deciliter.
Okay. Then what happens next?
If it's more than that, then the patient might get a respiratory depression. Respiratory arrest. For about 12.
Okay. So what's the therapeutic level? So your magnesium should be just how many? Up to around 4 to 7 megs per liter. Because more than that, it will produce your urine, it will affect your urine output, would have muscle weakness, and eventually respiratory depression. Okay? Your hypertension, how will you control post-op? What's the ideal postpartum hypertension medications that you could give?
We can give nifedipine, doc, as a drip.
Some will give this nifedipine. Okay.
Yes, po.
Your usual amlodipine and losartan, does it have a place in your pregnancy? Why do we shy away from giving amlodipine?
Maybe because it have a arrhythmic effect.
Okay. Some say it has effect on breastfeeding, but others beg to disagree. But because of that, before it was thought that amlodipine is generally not given. Okay. So, for example, this patient did not have superimposed preeclampsia and was just pregnancy-induced hypertension and not chronic hypertension. How would you determine if this is indeed chronic hypertension or just pregnancy-induced? When will you reevaluate?
If it's pregnancy induced, then the patient will not be hypertensive after 20 weeks of giving delivery, after the delivery.
20 weeks?
No, after 12 weeks. Sorry.
After 12 weeks. Okay. So you reevaluate after 12 weeks and if patient is still hypertensive, then it is already hypertension for the patient. If not, it is just pregnancy induced. Okay? I think this is my last. All right. Okay? So, in a nutshell, I tried to walk you through a pregnant patient and along a course of its pregnancy and how different managing your hypertensive patient would be. Okay, so aside from your normal OB prenatal care, of course, there are other parameters that we have to be wary of in hypertensive patients. Of course, we do not want the worst sequela of your preeclampsia, and that is your eclampsia. So the spectrum is chronic hypertension, your pregnancy-induced hypertension, and preeclampsia, or those two conditions with superimposed preeclampsia, and of course, at the end of the spectrum is your eclampsia. We do not want it to happen because it has a significantly higher morbidity, both maternal and fetal side. Okay. What are the maternal things that could happen? Maternal events that could happen? Of course, your eclampsia. We do not want that. Of course, we don't want your respiratory distress in your baby as well, or any obstetric indications that would warrant resuscitation. All right. Are there any questions for this SGD? Could you open your cameras and have our class picture for Rangi and then send to our chat? Sirisha and Macherla. Video, please.
Yes, ma'am, it's done.
Okay. Are you done?
Yes, ma'am.
All right. So see you Wednesday for your SGD on abruption placenta. It's actually a continuum of your hypertensive disorder. But what I want you to study would be your third trimester bleeding. So abruption placenta and its close differentials, placenta previa, and your vasa previa. All right. So see you on Wednesday. Thank you for attending this SGD.